Okay, I think we are live. So welcome back to the TRT and Hormone Optimization YouTube channel. And back with us, high demanded, is Dr. Jordan Grant. Welcome back, Jordan.
Hey, thanks for having me. Good to be back.
Yeah, hi, man. Thanks for
Yeah,
coming on again. It has
absolutely.
been a while. I've checked almost a year, I think. So
I agree. Yeah, we've had a lot going on, and I know you have too. But yeah, we've been renovating a house and traveling, and so hopefully we get settled down here pretty quick.
yeah, awesome. So the link that I've put under the video is still the same, Grant Hormones.
Yeah, granthormone.com. Yes, sir.
Granthormone.com. So for everyone who wants to reach Jordan, he can also do telemeds, but as I remember, they have to come into the office once.
So if telemeds are mainly in-state only, so Texas residents can do telemeds for now, unless they change that. They keep threatening every year to change it. For any out-of-state patients, which we've kind of limited out-of-state just because it's harder to get in and out of the office, but I'll still, make some exceptions. They have to be seen in person. Yeah.
Okay, I understand.
Yep.
So everyone watching, leave your questions in the chat box, and as long as we don't get any questions, I have some pre-prepared questions for Jordan.
Yay.
So let's start with this one, Jordan. What are some TRT clinic red flags?
Man, that's going to open a can of worms for a lot of people. And my red flag may be different from somebody else's red flag. I just want people to know that I have my own standards about certain things and what I like to see. And not everybody, those things don't matter to everybody. So I get that. I think in general, though, there are some things that if you kind of go through our group, you'll see common red flags that most people, at least in our group, kind of can agree that are red flags. And it depends on it doesn't have to be with a TRT clinic. There's red flags, obviously, from if people want to go through their regular provider, allopathic provider, whatever, or osteopathic, any mainstream provider, if they're trying to do the insurance-based system, they're going to probably have a harder time doing that. Most providers are not savvy to keying in on symptom resolution. They will still focus primarily on baseline lab ranges. That's a red flag, whether it's a TRT clinic or a regular clinic or whatever, in my opinion. So constant obsession with labs over the individual is a red flag. I think throwing people on multiple compounds at the first visit is a red flag, personally. And I know there are reputable clinics that do that, and they can get away with it in some people. But in general, I'm personally a one variable at a time kind of guy. It just makes more sense from a logical perspective, just to see what's affecting the body. So I do think if you go to a clinic and they're like, you need to pay us $1,000 for all these different meds at once, because I've seen it. I've seen people slammed on not only testosterone, but high dose thyroid, DHEA, pregnenolone, HCG, peptides, all in the first visit. And that's a red flag to me. I think those are the big ones. Obviously, aromatase inhibitor, prescribing and recommendation of frequent phlebotomies. Both of those to me, are red flags. Again, that's a personal preference kind of thing. I get it that some people are passionate about that topic and they demand they have to donate or they have to be on an AI. It's like, that's not a red flag for you. But if you're keyed into the discussion and what we've talked about and understand a lot of the fallacies involved in those claims, when you do go to those clinics and they start pushing it, that's a bit of a red flag. Now, you can oftentimes give pushback and work with certain providers who say, oh, no, it's okay. We won't, require that, or you don't have to do the AI. It's just here if you need it, quote unquote, which shows me they don't really know the topic. But, that's okay. Everybody's got to work within the bounds of the clinic and the finances that they have, But I would say those are the big red flags to me. That, and I think and again, I'm probably stepping on toes here, and I get it. Because we don't resell medicines or labs, so we have no dog in that hunt. Requiring patients to get these massive lab panels all the time, I think, is a red flag. Labs don't tell people what they think they do. It's massively fraught with philosophical issues when determining the meaning of labs, especially baseline labs. It's one thing if you're monitoring a therapeutic drug level. It's another thing if you're just trying to correlate a bunch of baselines with people, and you just can't do it. But they get package deals for these labs and they push them on people. And, now that the rise of the functional medicine world, which is kind of drives me nuts, they're claiming they're going to get to your root cause, but it's really just more and more lab tests. It's like, well, then that's not getting the root cause per se.
Yeah.
So just be aware of these kind of things. I'm not saying these are all technically red flags, but these are things to look out for. I think going like with the insurance route, if you do try to go the regular doc, that's going to be hard for you. I can't consider that a red flag per se, but just know that you're going to have some hurdles fighting with insurance companies, and then doctors who are still in that insurance model, you know, they just have a different mindset in general. Obviously, I didn't have that mindset when I was doing it under the insurance model, but I'm weird, you know, and you'll find some occasional ones who really enjoy providing hormones the optimal way and still have a regular practice. And so take insurance. And I mean, those are diamonds in the rough if you can find that. But I still think in general, I would recommend people not use insurance to get, at least not even to pay for their hormones, because you don't want insurance involved in any of your care. You don't want them requiring labs and doing, I've seen stupid stuff where they demand the patient be taken off his testosterone to see if his levels remain normal, or it's just like, no, you guys don't get it. So those would be my big red flags. I'd say there's probably more, but those are the big ones that we see most commonly.
Yeah. All right. So you just told us that you don't put people on different medications at first visit. But a question that I already had answered by another doctor a few weeks ago: if people are low T, very clearly low T, and hypothyroid, do you start them on both at once, or which one do you start with?
In my practice, it's a little different because I'm not necessarily checking before we have our first visit. We're not doing a massive lab panel. A lot of times they'll come with pre-done labs, but otherwise we'll focus on their symptoms. I'm more about symptoms than numbers. Like, I'll just give you an example. I have a normal thyroid panel, and yet I take NP thyroid and feel better on it. Just the same way, a lot of people can have some abnormal thyroid parameters. Doesn't always mean you need thyroid, especially when you start them on testosterone first. And a lot of times they'll get their lifestyles in order a little better when they're taking the testosterone, and they feel great. And then I'm like, well, then I'm not going to go just off of a thyroid panel per se when you feel well. So for me, and the way it sort of happens in my practice in general, we're not exploring the thyroid part at the same time. If they already come to me from another clinic and they've been on, let's say, thyroid, like levothyroxine, Synthroid, something like that, we will discuss switching over to a desiccated thyroid. I still try to do testosterone first, leave them on the levo for at least 3 to 4 weeks while they're getting adjusted to the testosterone. Then we still address the thyroid conversion after the fact. That's not all of them, not 100% of cases. I think there have been some where like, no, I want to go ahead and switch to NP. I'm ready to, you know, they've hated levo for as long as they've been on it, and that's fine. I just tell them we're messing with 2 variables at a time, so you just got to be open to knowing we may not know what's doing what.
Yeah, sure. Yeah. All right. The other question I had. Let me check. I had some questions about debunking common TRT misconceptions. So I guess we should talk about TRT is bad for your heart, TRT is bad for your prostate, you have to donate on TRT. So all these typical misconceptions, where do they come from, and why do other doctors or a lot of other providers keep on repeating them?
I mean, that's the general question for humanity, right? Why do we repeat things that we've never looked into as fact? And my gosh, look at the last few days, what's going on right now with people speculating like they know what's going on with certain events in the world. They don't. We like to drum up stories in our head. And when it comes to hormones, the amount of storytelling around them, and I think a lot of it, and I'm speculating here too, I don't know why the misinformation is the way it is. I noticed it in med school because, you know, I grew up studying steroids, researching things when I was in high school and later into college. Like, I really enjoyed the topic. And even then you get a feel for how people think about hormones and even just general testosterone replacement. It gets this stigma. And I think it probably is because of the performance enhancing world, maybe the abuse side. And they equate the two things, which is a total non sequitur. It doesn't follow that because you can abuse something that using it is wrong or dangerous. You can abuse water or whatever, you know, I mean, it's just insane. But that just sticks, and you hear it from, I mean, I heard it in med school over and over and over again, even from just med students who didn't know anything about anything yet. And, oh yeah, those hormones, they're horrible. I can't believe somebody put somebody on hormones. And So I don't know the motives behind it. I don't understand the mindset. It just is out there, and I think it's slowly getting better. I'm seeing a shift in some of the physician groups I'm in on Facebook. A lot of urologists especially are wanting to get into the hormone space, but they still are believing a lot of things that are wrong, but at least they're more open to even doing it. I mean, 20 years ago, there's like, no, you don't need that. It's just crazy. So I don't know the whys, but people repeat dogmas as truth without looking into it. They've done this for several things you mentioned, right? They've done it for things about donating blood, the high hematocrit, on testosterone replacement, prostate cancer stuff, estradiol. Those would be the three big, I would say, misconceptions. And then the heart disease, stroke risk, that's thankfully been looked at in meta-analyses at this point. Like, you can pretty much mark that off the list. And I don't like statistical studies because you can't compare something inside an individual to themselves. You're comparing different people in different groups, and then you're looking for differences. It's like, yeah, but you don't know what would have happened in that one individual over time, whatever. But it's the best we have. And if you don't see an increase in association, maybe you can at least mark it off as a causation. And that's kind of the best I see for those kind of studies. So I think when you see that in the studies done on cardiovascular risk, cardiovascular disease, MIs, strokes, DVTs, there's just no increased association with that. And I don't even see that they're controlling hematocrit in a lot of those studies at all. That's what I always tell people. But there's no evidence that increased hematocrit as on its own, like that lab value, causes anything bad, like causation wise. People speculate all day long about viscosity. They call it thick blood. If you go and look at viscosity research, most of it's all done outside of the body. You can't actually check the viscosity inside the body. And if you look at some studies done, the viscosities are actually worse in those with lower hemoglobin hematocrit, at least in ape studies and things like that. They don't really study this in humans. There's not a good incentive to study it. But from what I tell people is, here's my philosophy on it. And if other people disagree, I'm fine with that. We all have our boundaries. My philosophy for all these things is, if I don't have actual evidence to recommend an intervention, I cannot in good conscience recommend it. What I can tell you is those interventions come with costs themselves. So in my mindset of, as a physician, do no harm, how can I recommend somebody do a procedure or take a drug without any evidence behind it when I know doing those things can actually cause harm? So that's my stance on that. Whether it comes to frequent phlebotomies, which can cause harm, you're literally mimicking a hemorrhage acutely, and that causes a cascade of things in the body, and it also causes overcompensation. We see it all the time in the Facebook group, right? Mm-hmm. I keep donating and my hematocrit ends up higher than it was. It's like, yeah, that's pretty normal. Human physiology, the body is designed very well. And so it will respond accordingly. And so you would have to bleed out pretty frequently to keep that number low. Well, then what are you doing? Why are you doing that? All to chase a number that nobody can prove is a problem. And so that's my first thing on the myths about hematocrit hemoglobin. Prostate cancer, thankfully, has been looked at for at least 20 years now, and they've kind of debunked all that myth that testosterone either causes it or even fuels it. I hope that spills over into the female world soon, because the same dogma is repeated about estradiol when there's just no good evidence for that. Now, is there evidence that some hormones can cause harm? Yeah, but not all hormones are the same. People like to make these hasty generalizations, right? And they put everything into one category. It's just like people do with carbohydrates, in the because these few over here may be bad, therefore all carbs are bad. It's like, no, everything stands or falls on its own. So it's going to be the same thing with these hormones and cancer risks and things like that. But I always tell people, of course, if you have a hormone sensitive tissue that becomes cancerous, or a part of it does, it's still going to be hormone sensitive. The hormones aren't causing that. And of course, if you withdraw the hormones, you might see the tissue shrink away and shrivel. People equate shriveling a tumor with a good outcome, when it's like, you don't know that doing that is actually doing anything for why that cancer is there in the first place. You're just chasing an effect, right? You can do it with chemo. I could cut off a blood supply to a tumor and shrink it. That has nothing to do with the total health of the person. So people don't, I think hard enough on these topics, and they're chasing effects instead of chasing root causes. But again, there's no evidence that testosterone causes or fuels prostate cancer. I think I've talked about this before. I had guys as a practicing urologist who had prostate cancer, like low grade. They were doing surveillance, and they wanted to be on TRT. And based on the many studies done on that with Dr. Morgenthaler's group, I was comfortable doing that. And guess what? None of them that I ever saw had sudden rapid progression of their cancer. In fact, a lot of the PSA numbers got better. Not that PSA is a great test. It can change all the time. But in general, people with prostate cancer, it will slowly, rise over time. And I would see their PSA numbers improve. And is that because their health got better? I don't know. That's all speculative. What I saw was no increased risk, and they felt better. They felt like humans again. So these people that are wanting to castrate them or keep them castrated, all to chase a PSA marker on its own, they're not taking into account the whole person and what their goals are in life and their desires, And then as far as the estradiol, I mean, that's the one we've hammered before. That's a big myth, misconception. I'm going to be talking about that this coming November at the Silverback Summit. I'm going to give a little talk on estradiol again, just kind of a refresher. I think it's good to rehash that topic over and over again. But what people don't understand is that they chase again a lab number that can't really be validated to mean anything at all. A serum estradiol value in a male is pretty much useless because at least according to the research and how it's done, the aromatization process takes place once testosterone enters the tissue itself, and then it converts, and that's going to happen in varying amounts depending on the tissue's needs and all these other things. So it's essentially an intricate process, which we talked about, and measuring a serum level, you don't know what it means. And it will always be above normal pretty much in anyone taking testosterone, because those normal values, baselines, are not obtained from people taking these compounds. So you would have to have a whole different set of normals for people on the hormones to even get a statistical distribution. But even then, statistics don't tell you anything about where one ought to be as an individual. So that's the philosophical issue there. So yeah, those would be the big misconceptions, or the little ones like, oh, it's going to give you roid rage. You're going to rage. You're going to be an angry person. I don't see it. Honestly, I take testosterone. I'm taking steroids. Like I didn't rage with any of them. But in general, my guys get on testosterone feel completely better. Their moods improve. And I know you've seen it too. We see it all the time, just how much better people feel in general, a little more just resilient to stressors. Now, I do think some people, when they get on testosterone, if they've been a bump on a log for a while, they may become more assertive as they're feeling better. And that can come across, let's say, to a spouse, a wife that was used to running the show. That can come across as angry, right? Well, okay, if you want to call it that, but he may just finally be feeling good enough to like assert himself. And I have seen that happen. But in general, I just see people's moods improve. I don't see the rage and all this stuff. So
maybe one more. You're going to lose your hair because you're on TRT.
Yeah, again, there's plenty of guys. This is my whole thing. I'm like, not the majority of men in general will lose their hair over time, TRT or not. That's just the way it is. So you can't prove that TRT ever caused it in the first place. A lot of people will see shedding, but shedding comes cyclically too. Like there's different growth phases and things like that. Stress. I mean, we're all under so much stress in America, especially, but westernized countries, you can lose your hair for lots of reasons: poor food, poor diet, poor sleep. But it's not a given that taking testosterone will cause you're going to lose your hair. But I do want men to understand that it's going to be a fact of life that most of us will have hair recession, at least at some point, or in certain places. I mean, I'm getting it here, right? It's just part of it. And I don't think twice about it. The guys who, I understand the desire not to lose the hair. Like I don't want to, but at what cost are you going to try to prevent that? And that's where I try to counsel people that if you really want to preserve it, I mean, you're going to probably have to do something radical, whether it be take some kind of pill that you hope works that's going to wreck your health, like a finasteride or minoxidil or something like that, or you go and get surgery done, a little transplant. And that's probably, at the end of the day, if you really want to maintain your hair or have more, that's probably a smarter way to do it, honestly, than taking drugs. Because the drugs don't do what people hope they do per se, and they do cause harm. And so that, to me, again, do no harm. It's like, I can't, if guys want to do it, they'll tell me, patients will ask me about it and I'll counsel them. I wouldn't recommend it, and I won't prescribe that. If they want to do it on their own, go for it. I do recommend, if you're going to do something, and not do surgery, do a topical over a systemic. You're still going to absorb some of it, but you may have a less systemic effects doing topical than a pill.
Yeah, sure.
Yeah.
All right, that was enough for the misconceptions and myths.
Yeah.
Yeah, there was something here about estrogen management, but we just talked about that. And then, there was a question about SLUPP, some call it Sloop 332 and TRT. Is it worth it?
Man, I had to go dig into this rabbit trail because I don't keep up with a lot of the hyped peptides right now because it's insane how I get like 5 or 6 messages a day about peptides right now. When a year ago it was hardly anything. So I don't know if people are hyping these up on talk shows all of a sudden right now. I assume they are. These peptides, a lot of them have been around for years. Bodybuilders have been playing with these things for a long time. Most of them go in the trash bin because they realize they don't do what they're promised. The Sloop, from the only paper I really could find on it that was worth reading. Again, the problems are people think you're going to find exercise in a pill or an injection. You're not. You're chasing markers that they equate with exercise. But just because you can look at certain markers of things like fatty acid oxidation or whatever, doesn't mean that that's happening for the same reason as it does in exercise. This is the same mistake I see people making a lot of like the carnivore groups and everything when they associate, fatty acid utilization with burning body fat. Oh, your body's switched over to burning, or the keto group. They've been saying this forever, right? You're burning fat as fuel now. It's like that has nothing to do with whether you're losing body fat or not, first of all. And if you look at the actual study done in these mutant mice who are not humans, the numbers and the differences achieved were not that different. If you look at the actual scatter plots, not just the bars, but go look at the individual variations between the groups, they're all over the place. So this is another problem with statistics, is that you can make anything kind of look significant when if you look at the individuals, you're like, well, it didn't matter for that one. It didn't matter for that one. That one still gained weight and this one didn't, And so that would be my concern, is that people are always chasing the easy fix. And if this works, if you take it and you lose fat by not changing anything, more power to you, but you don't know how that's doing that in the body. You don't. Any claims that you know exactly what all these medicines are doing to the body as a whole, you don't know what they're doing. And so it's my same concern I have in a similar fashion with the GLP-1s and things like that. Do they work? Yes. Do we know how those work? Yeah, in general. You're stopping the gut from doing what it's supposed to do, so you feel full, right? You're essentially paralyzing your gut and inducing gastroparesis. Any of these claims about what it does in the brain, you can't validate it. In general, we know how those work. These other ones, I don't know. Look at like DNP. That works, but it ain't healthy. It ain't safe, and bodybuilders know that. They admit it. And I think that's the main thing here is like, if you educate yourself on these things enough to go, okay, I don't really know how this thing may work. It may not be healthy, but I don't care. I want to try this as a guinea pig for myself. That's great, because then you have informed consent to do it. You have all the information. My problem is when these things are just pushed as miracle drugs, and nobody goes into like, oh, okay, but watch out for this, this, and this, and we don't know what it's doing. They'll just push it as, you got to take this thing, man. It's a miracle, and it's just not. But yeah, the study I found, the main study I could only find was really one study in these mutant mice. Everything else were peptide research chemical websites promoting it. So again, there's no issue taking it with or without TRT. I don't think the TRT part has anything to do with it. Like TRT is its own category. I don't see that conflicting with any other experimental peptides somebody wants to take per se.
Yeah. All right. Talking about training, there were some questions about overtraining myths. That's something I always wondered about myself. I've been training for a long time. I've never felt anything about overtraining. I never do deloads. I just keep on training. Is there such a thing like overtraining? Have you experienced it?
I don't think I've experienced what I've read about as overtraining. Like it's like this mythical unicorn that you hear about. And I think it would probably take a lot to get there. It's not that it's not real. I think there are elite athletes who can probably, or CrossFitters maybe even, who kind of go to certain extremes and end up, if you want to call it overtraining, or end up with rhabdo or something. Like, to me, if you end up with rhabdo, you've probably gone too far. And that is a type of overtraining. Yeah. I think you can overextend yourself and drive yourself into the ground if you're doing, depends on your workout routine. That's all it comes down to. The way I work out now, there's no risk of overtraining at all, but I'm in maintenance mode at this point. I literally do a couple sets per body part every 8 days with intensity, you know, rep range, you know, 5 to 10, going close to failure, not losing any muscle, not losing any strength, and I feel recovered. Now, if I started pushing, I will say probably 7 or 8 years ago, I was trying the high volume approach, you know, and high frequency. So high volume, high frequency. So trying to hit everything twice a week with, you know, 10 sets per body part at a time, you know, I mean, so 20 sets a week sometimes on something. I never got to where I was like in a coma or anything, but I was not progressing in the gym. And so to me, that's a sign of overreaching probably and not giving yourself time to recover. I mean, that's why people do deloads. Is to give yourself that planned recovery. And I have done deloads before, but usually only probably more in a calorie deficit when I'm dieting. I feel like they help because you can go to a maintenance phase of your diet for a week and it's just psychologically beneficial. Whether that actually ramps up fat loss faster, I don't know if there's any truth to that. But from a psychological standpoint, it's nice to give yourself a break, cut down on your volume and intensity for a week and just live life and then go back into it. And it just keeps the motivation going. But yeah, I haven't done any research into overtraining because I don't really think about it much. I don't think most people are even close to that point. And so I don't think it's something that needs to be on the radar. I think what needs to be on the radar is learning about programming in general and the whys of how, you know, what the research at least kind of indicates as far as how to make good progress, how to program your lifts, knowing reps in reserve and how to judge intensity and effort. And then listening to your body to see what exercises work and what don't, you know? I mean, so many people just read a routine or read comments and think, oh, okay, I have to do these exercises. And they'll run themselves into the ground with injuries because their body mechanics aren't built for that. Like I can't squat. I can't. The only kind of squat I can really do is like on a Smith machine where I can really hammer into focusing and keeping my back perfectly straight against the bar and push into it. If I have to do a free range of motion squat, my hips are so messed up and my levers are weird, you know? And I found the same thing with benching. Like I never got any pec stimulation out of it, but I kept doing it and hurting my shoulders. And finally I started doing machines and cables and flies. And it's like, oh, hey, I'm starting to get a little bit of a pec now. I don't have good pecs anyway, but it's like all these years I wasted just because I thought I had to do something a certain way. I know that's a tangent from what we're talking about, but I think in general, people just need to learn smart programming, how to do it on your own, and then you can make adjustments over time based on those principles that you already know. And you'll probably avoid overtraining too, because you'll learn how to listen to your body and notice if your lifts are constantly, like when I did I think it was Windler's 531 years ago when I was in med school, I ran myself in the ground on that because I'm doing these crazy heavy workouts, but like 3 times a week, total body with like power lift level rep ranges, and I could never progress that way. And I think some guys are cut out to do it that way. And obviously if drugs come into the mix, that changes everything. But for a natural lifter, you don't need to do anything insane. It doesn't take as much as people think to stimulate, you know, stimulate, don't annihilate, you know, get it done, get out. And so I've actually gone back to more of a heavy duty training philosophy in general, not per se Mike Mincer style, but there's lots of variations of those like Max OT and all these others or Dante Trudell's, you know, dog crap training. You're hitting it hard. You might do some rest pause and you get out and you recover and you just do it again and then just monitor progress. Yeah.
Yeah. You get wiser getting older anyway.
Hope so.
Yeah, you live, you learn. Dave Lee asked me to ask you how to get arms like yours, Jordan.
I have always had decent arms, even when I was a kid. And the minute I picked up barbells, but nothing else followed. So people ask me that, you know, on our trip recently, I have a tank top on. They're like, "Oh, what do you do for your arms?" I'm like, "Nothing really. A couple sets of hammer curls twice a week." You know, I mean. It just is, but I'll ask guys that who have good pecs sometimes, and they're like, "Yeah, I've always had good pecs." So yeah. I think again, play it smart. You're gonna hit your compounds, throw in a little accessory. These guys spending hours on arms, you're spinning your wheels, in my opinion. I think if you need a specialization routine to bring them up because you're a bodybuilder, that's one thing. But in general, if you're doing the good basic lifts and then you just hit the rest, you know, a couple times a week, not killing them, you'll be fine.
Yeah, sure. Another one was about IGF-1. I know on the channel we haven't talked much about IGF-1. What are your thoughts on it? I guess you don't recommend patients use it.
You talking about like exogenous IGF-1, or are we talking about? Yeah, this is something even in the bodybuilding world that used to be touted as like that was the next thing, right? That was going to be the next big thing over GH. And I know IGF can provide some benefits. I think the majority of what I see are guys getting better pumps in the gym and things like that, fluid retention. And I'm like, well, how is that inducing fluid retention? First of all, it's always a good thing, right? You don't know the mechanism in the body that's causing it just because it gives you an advantage. I haven't seen, like, I know I've had some guys use IGF LR3 that's in the last few years. I've not been very impressed with what I've heard from them as far as bang for buck over something like ipamorelin or something like that. That just seems to tick a few more boxes. I'm not against it. Again, people want to use these things, go for it, see what happens. I don't really prescribe the ones that haven't been at least studied in humans very much. And so I'm not that comfortable doing that, but a lot of providers will. Now, IGF-1 in general, that's the other thing I wanted to talk about is people get hoodwinked and get focused on like baseline IGF levels. And they try to like make claims about, oh, I'm low. It's like, these are also all over the map, and you can't tie and pin these down to anything causative in the body at that time because it's just a baseline. It's not how baseline labs work. And so the best use for IGF, I think, in my opinion, from a serum blood testing standpoint, is usually just to assess the value of the growth hormone somebody's taking. Exogenous growth hormone should typically show that rise in IGF. I mean, that's what you see people say to check if you want to see if your GH is real, right? You don't see those increases as much in guys on the peptides, GHRPs and things like that. But I tell guys that's okay. Like, they freak out about it. They think, oh, because it's got the word growth hormone releasing in it. These are two different categories. And I know this is going to get me in rabbit trail territory with people, but people don't understand the difference between the exogenous substance being given and studied and what happens versus the claimed endogenous hormone that they claim they're studying. If you actually go look at how they study these things originally, you can't study that internal hormone the way people think you can. What they've done is they've derived these hormones through chemical processes with animal tissues or whatever, transformed them into something that they then claim is there originally, which may or may not be true. But then they study those man-made compounds, growth hormone, this precipitate that was obtained from a dried up pituitary gland that they did a lot of chemicals to and called it growth hormone. Well, why do they call it that? Because it grew certain things in a petri dish or a test tube. Same thing with IGF-1, right? That's how they came up with the idea of it, is they noticed that putting GH into these like tissue cultures would not stimulate cartilage growth. But if you took the serum of animals who'd been treated with growth hormone and you applied that to these tissue cultures, that would induce cartilage growth. So they were like, oh, there must be a transformative property in the blood of these GH given animals, right? And that's how IGF got its whole start, right? And that's fine because you're kind of getting a correlate between exogenous GH and then something in the blood that you can call IGF-1 and what that does as a downstream effect. Making any claims about that from baseline levels, none of that matters. Like, so all these people freaking out saying like, oh, IGF and cancer. It's like, no, just because you can correlate somebody's baseline IGF levels and say people with cancer may have higher IGF levels, that has nothing to do with causation. The IGF-1 levels just may be increased because they already have cancer or for some totally irrelevant reasons. So that's where I think I wanted, I harp on that a lot. And I don't know that many people think about it like this, but they're just two separate categories. Baseline levels are over here. Levels via therapeutic monitoring when a substance is given are over here in this category. And these are not the same. And that's just the important thing. I had a guy come to see me, and he's a biochemist. And he came to see me as a patient. And he started looking into the normal ranges, and he's like, doc, I couldn't believe it when I saw that these ranges were not derived from people taking the hormone. Because in his world, pharmaceuticals, you think about therapeutic drug monitoring, drug levels. So in his mind, he was like, that's how this should have been done. And I'm like, yeah, I know. But everybody just goes off these normal ranges, which are massive, 200 to 800, some nonsense. Like, well, that's meaningless. So I just wanted to throw that out there, that these are two separate things. And I don't want people to get hung up on the IGF-1 baseline stuff as much as they do, because I think it causes unneeded stress, like most of these baseline labs do. But if you want to take IGF as an exogenous thing, again, you got to know that what you're getting is real. We don't know that with half of these things. If a compounding pharmacy is making it, it's probably legit from that standpoint. But is IGF LR3 the same thing as IGF that was taken 20 years ago in the body, I don't know. And people need to be careful with any kind of these exogenous things, because you don't know what all they're doing in the body. And as long as you're okay with that, that's fine. But I wouldn't push it on unsuspecting public who aren't going to go into all that and assess the risk reward in their own life like a bodybuilder would do.
Okay, maybe let's talk a little bit more about growth hormone. Take me, for example. I'm 51. I'm on TRT since 8 years. I take Armored Thyroid, and I feel fine. I'm optimized. I can work out. I have a good libido. Everything is fine. And what is the next step in optimization? Would you recommend trying growth hormone or maybe a secretagogue? Or would you tell me, yeah, just leave it alone, you're fine?
I think it depends. And I have guys that ask this a lot. They say, hey, doc, what can I do? What else can I do right now? And I'm like, do to what? Do for what goal? You have to have a goal. Don't just take something to add it to take it. And that's what I tell people. First of all, you need to have a goal in mind, something that your current protocol is not doing.
Maybe longevity, but that you don't know.
You can't prove longevity at all. Like, I can't stand the longevity research. I can't stand it, because you're looking at these markers that may have nothing to do with anything. So in general, I think the body's pretty smart. And when you feel well and are humming along and ticking boxes, that's the best situation. And that's the good thing. If you do want to add something, if you're honest with yourself and you feel worse, stop taking it. Or if you get nothing out of it, don't take it. And that's what people get hoodwinked with supplements and vitamins. They feel no different on them, or sometimes feel worse, but like, no, I just have to take them because I've been told I have to take these. No, you don't at all. I take none of those. I feel better than ever. Right? I eat whole foods now. I eat real food again. Like, it makes a difference. But as far as GH, like, I've been curious myself about it because I do like being my own guinea pig and trying things. I'm not against people trying things. Do you need it? No. Need is a subjective term anyway. Like, what need for what? If you need it for the effects that only it can give, well, then yeah, you need it. I think I've seen a lot of people, their skin, it can help in the skin and the nails and the hair health. I mean, it seems like it can. A little bit, probably better body composition. It's not magic. It's not going to, let's say, melt fat away unless I think you hit the high doses like some of these guys do. And you may see magic happen, but you also may see some negative magic happening to your organs and your blood sugars and things like that. So there's always a cost with all these things. And again, I think it's worthwhile to explore that. I think GH is off limits for most people from the cost perspective. Like, I mean, we make good money, or we did when we were urologists. I looked at the cost of growth hormone for like 1 IU a day of real growth hormone. There's no way my wife would have been okay with us paying for that every month. No way. So I think that's going to be the big one, is cost prohibitive for most people. It's very tightly controlled in the United States as far as legitimate prescriptions for it. The secretagogues, I don't even think about them in the same category as GH because they're just not. But they do have some benefits. I tried ipamorelin CGC 1295 a couple of years ago, and because I have a crappy sleep and I'm a light sleeper, it helped me sleep better. Now, is that a good thing from a health standpoint? Like, how is it inducing it? I don't know. I didn't feel worse on it. I felt like over the couple months, I didn't really change my diet. I felt like I maybe started seeing a few more veins in my shoulders. You convince yourself you can see anything, and that could be a million things causing that. But I do think my recovery was better because I was still working out pretty much the same. I didn't notice the soreness as long. So again, that's all anecdotal, but I think that's the whole point of all this, is try it and see. Same thing with thyroid. I've done the same thing. I take thyroid, even though my panel was normal. I feel better on it. I'm not getting negatives. I'm not getting sweats. I'm not, shaking. I'm not getting high heart rate. I've taken T3 before. I know what it can do. I think Armour is way more gentle. And it just seems to cause a well-being and mental focus and clarity, and just ticks a few extra boxes. So that's my thing, is if you're already optimized on testosterone, lifestyle, diet, and you don't feel like there's anything missing, maybe don't mess with the good thing. If you're like just wanting to experiment on yourself, that's a different category altogether. But when we talk, I think we used to use that term optimizing probably too flippantly. And now I've realized there's a lot of subjectivity involved in even that word. So it really is kind of like Broderick Chavez always says when he's talking about anabolics, right tool for the right job. But you got to know the job that you're wanting to get done, and then explore the tools and see if they tick the box that you want them to. And I think it's very pragmatic, but I think that's what all this boils down to in the end.
I read somewhere that when you're older, maybe over 45, the secretagogues are not worth it anymore because they can't stimulate enough the pituitary glands.
Again, you're going into like, they're going into like mental wanking territory there, when it's like, okay, if I take this and I'm 50 and I get better sleep and recovery, who gives a crap? Who cares? All I'm after is that effect. That's what I want. I want to get it done. I don't care about the mental mechanisms people are coming up with to try to explain what's going on. I don't think they can know it. People don't know as much as they think they do when it comes to processes in the body. I'll just put it that way. I think even Huberman admitted that on Bill Maher, you know, talking about like, well, we only know 10% of what we think, you know, it's true or what. And it's like, I don't even think it's that. I don't think most of it, they're all heuristics and mental models to try to make sense of how a drug might work, but nobody actually knows. What we know are effects. What we can see are, when we give this, what happens? And then you have to determine if that's a desirable thing. Well, that's subjective. Then you have to determine if it's a healthy thing. That's hard to prove sometimes, you know, because what if it's fine for a while and then it gets over time? I mean, everybody has to choose their own risk reward ratios with this stuff. So I've just been way more pragmatic over time.
Yeah, awesome. All right. One last thing before we switch to the chat box. What was it there? Oh, yeah. Let's talk about the reasons that some men have for stopping TRT. I read that a lot also in the Facebook group we manage. Yeah, it didn't work for me. I just stopped. Do you hear that a lot in your practice?
Yeah, I don't have a lot of guys that stop. I've had a few that just feel like, yeah, I mean, we've tried multiple things and it just never ticked the boxes they wanted it to. I will say usually that is all about, and I try to do this at the very beginning, set expectations. Expectations in life are everything. Yeah. What is somebody expecting to happen versus what is appropriate to expect, you know? And so there's a mismatch there. A lot of guys think that when they get on testosterone, it's going to turn them into Arnold Schwarzenegger, or they're going to be this way in the gym, or they're going to look this way, or they're going to want to have sex with their wife now every day. And it's like, that's not true. Even though we set those expectations up front, some guys still have it in their head based on buddies they're talking to or stuff they're reading online, and they get that in their head, and then they're disappointed when that doesn't happen. And I get it. That's totally legit. If it's not right for them, it's not right for them. I think in a lot of the group, we see guys stop because they were given pretty crappy protocols to begin with. So they're being thrown on aromatase inhibitors, poor injection frequencies, not willing to explore symptom resolution, frequent phlebotomies, all the things, the red flags we talked about, that will drive people away because they're like, yeah, I got on this and I was promised the world and I actually got worse. And that's the red flag. When you see guys in general, people should not get worse if you're doing TRT the right way, in my opinion. Now there can be some transient time periods where things get worse, like those first 4 to 6 weeks or a couple of months with water retention and weird things happening because your body's just got to get used to it. That would be another reason people probably prematurely stop, is they're not willing to give it enough time. A lot of guys think that these results are going to come quicker than they should. And then they get frustrated. They're like, oh, I had a guy who was like on it 2 weeks. He's like, I don't feel any different. I'm like, I know, we talked about this many times. Like, you're not going to feel different yet. This is a long haul thing, and you still have to work on your lifestyle. That's the other thing. A lot of guys drop out because they're not willing to address all the things. Now, some do. Some come and they're hitting all the boxes already. Those are the guys that generally get better on TRT, right? Because they're already doing all the right stuff, but there's still that one missing piece. Throw that in and like, yep, that was it. I'm great. I'm good. But these guys that like you try to really talk to about all their multifaceted variables in their life, and they acknowledge it, but then they get on the testosterone, they just want it to do all the work. And then they get disappointed when that doesn't happen. And I'm like, have you changed your diet? Show me what oh, well, no, we're still busy. We're still doing, I'm like, there's no excuses. Those are excuses, but you can overcome them. Like, you just have to want it. And that's like with anything in life. If you truly want it, you'll make it happen, you know, in general, especially when it comes to dietary choices and food. I mean, anybody can make enough food on a Sunday and a Wednesday to last them the whole week. I mean, you just can. It doesn't have to be anything fancy. You know, I ate ground beef and rice for lunch every day and I got leftover the next day. It's not hard. It takes me 10 minutes, you know, to do that. So I do think that's a big part of it, though, and that's not just in the hormone world. That's in a lot of things in life, is expectations are not properly set. And then people get disappointed when their own expectations aren't met and they drop out. And it's like, well, you had the wrong expectations on that. That's not everybody. There are some people it It just doesn't work. You know, it doesn't tick the right boxes for whatever reason. A lot of guys will drop out for fertility purposes because they're told they have to. Not in my clinic. I've had a few that do it on their own and then come back and tell me, and I'm like, why didn't you reach out to me? like I can walk you through this. You know, that's why I'm here. That's part of the model. I'm available all the time because I would tell them, no, we can do FSH, HCG, all these other things, and it works almost every time. So, but a lot of guys are ripped off their testosterone from their providers to quote unquote regain their fertility, and then they feel like crap. Yeah. So that would be another dropout, even though it's not really necessarily a voluntary one, probably on their part per se, but they're being fed something that's not true. And the same thing with hematocrit stuff. Like they'll be told you've got to, you know, I see primary care providers all the time. They'll tell people, they'll check their hematocrit and it'll be 54. And they're like, you got to stop your testosterone for a month. It's like, what is wrong with you? What are you talking about? Like 10 years ago, 55 was top of normal range. Like, first of all, but they don't even know that. So it is what it is. But those would probably be the main reasons for dropout. I would say poor protocol and wrong expectations.
And could it also be that they don't feel optimized yet because they need some other hormone optimized, like DHEA or pregnenolone?
Maybe. I haven't quite seen that yet as far as the dropout part. I've had a few guys where we did add like pregnenolone and that ticked the one remaining box, but they were never going to stop their TRT because of that. Yeah, that was an extra thing where you're trying to tease through and go, well, can we find something else that might tick that box? In general, I've only seen that a few times. I'm not a huge pregnenolone DHEA fan. I think preg over DHEA. DHEA is kind of dirty to me in general, as far as the effects I've seen in a lot of guys who try it, and myself included. But everybody's different. I know Dave's a big fan of it, but I think he would agree. It depends on the person and depends on the context. But yeah, for most things, they need to dial in their lifestyles first before they start searching out other chemicals. That's the main thing I see. And I see the same thing with guys on TRT who aren't getting the gains in the gym that they think they should be getting. And so they're like, oh, I want to add Anavar. I want to add this. And I'm like, send me your workout routine and your diet, first of all. And they're not there yet. They're not even close to being there. And I'm like, you can't go start jumping on anabolics when you're not doing the basics. Testosterone by itself, even in quote unquote replacement doses, can do more than people realize from a muscle building standpoint. It is very powerful. I am able to lose fat without losing muscle in a calorie deficit on testosterone cream by itself, nothing else. The myth and fear that I used to have of losing muscle, I think it's because I used to work out the wrong way when I was dieting and not have my nutrition dialed in while I was dieting the right way. And now the testosterone on top, I don't really have to worry about it. Now, yeah, if I wanted to get stage lean and still maintain every ounce of muscle, would I need to add an anabolic? Maybe, but a lot of those are cosmetic only. And that's the other thing people don't realize about a lot of these things they want to add. I got guys asking about adding like Anavar to their TRT regimen. And it's like, why do you want to add a methylated steroid? Are you going to take this long term? Like, I wouldn't. And then in general, those are just cosmetic effects. Like from a muscle building standpoint, these are pretty equal across the board. Testosterone, nandrolone, Anavar, like as far as nitrogen retention, all these things, these markers that they look at. But it's the other effects people are after that they want to take. So a cosmetic effect from an oral, well, fine if you're getting ready for a photo shoot or a competition, but something just to be on it, like, no, just work out harder, bump up your testosterone. If you're going to go the underground route, try testosterone first. I mean, really. And if you can't tolerate it, okay, fine, try something else. But in general, people just want to add stuff, I think, because they feel it's the FOMO, right? It's their fear of missing out. And they hear all these people constantly talking. I used to have that in the performance world, in the steroid world. You always want to do these exotic cycles, try these different things. And at the end of the day, the meat and potatoes basics works. Low and slow works. You don't need these gram plus unless you're at that high level. But if you're just a gym rat wanting to look better, man, a little goes a long way. You just need to dial in your nutrition and your training and your stress and sleep, and the hormones are just the icing on the top. Sorry, that was a tangent.
Exactly. Okay, thank you, Jordan. Let's have a look at the chat box. Why do I start having troubles maintaining erections when my dose goes above 180 milligrams a week? It's frustrating because everything else at that dose is awesome, great sleep, joints feel great, strength goes up.
Yeah, I don't know why. I see it all the time. I've seen it myself. And I had this conversation with a patient last week. Like, there's this point of diminishing returns, and there's also this seesaw effect where you keep going higher, and all these things get better, and then these other things get worse. And it's usually libido and erections and resting heart rate a lot of times too. Guys will get elevated resting heart rate, feel anxious, tight-chested, but not always. Sometimes it really is the erections just won't maintain. I've been there, done that, and lowering my dose, that it did the trick. And I can't give you a mechanism for it. I don't even want to speculate. But again, we're all we care about is the reality of this. Just seems to be a thing for a lot of guys. You just have to be willing to find the balance. Because if you're trying to chase perfect in those other areas, you've got to be willing to sacrifice. You can't hit all the boxes at once per se. And a lot of guys, like we'll add tadalafil to overcome that. If you want to take the higher dose androgens, you got to add something to maintain the erection, and then you're adding more chemicals into the mix. It just is what it is. I mean, talk to a bodybuilder sometime on high dose stuff. Their penis doesn't work right most of the time. Okay, it just doesn't. Not without taking some things. It's just part of it. There's something about the body and the dose response relationship where the higher you go with certain hormones, things go backwards in certain areas, and it just is what it is.
Yeah, so you made it sound like low dose tadalafil continuously is a bad thing.
No, I don't mean it like that. It's just, I think people have to understand you're still band-aiding something, right? You're still taking it, and it's okay if you're okay with that. I am. I don't take it every day anymore. I'll do it like twice a week is really all I need. It's got a long half-life. So I like the effects. Is that fixing the root cause of why I might have been having the erection dysfunction? No, not really. So that was my point. Just realize you're sort of band-aiding it. I think tadalafil in general is pretty safe pharmaceutical compared to the majority of pharmaceuticals out there, at least from what we know at this point. So I'm not against it. I take it. I just want to caution people to think like because some people don't want to have to take anything if they don't have to. And I'm like, you're going to have to decide if you want to ramp up your doses and your erections go away. They want some magical answer or magical fix. And it's like, nobody knows the cause. So if you need to take care of it, take some Cialis and see if that does the trick. Like, that's my point. Just be practical about it. You just kind of gotta accept the reality of what you're doing and the consequences. And we all have to with these things, because there's so many mechanisms at play. We don't fully grasp it. So that's all I meant by that.
Mm-hmm. Here's a question that keeps on coming back. What is an alarming hematocrit level? Is under 52% safe, 100%? And how to reduce red blood cells?
Don't need to. There's no evidence you should. If your red blood cells are out of whack for a pathologic reason, you have to find the pathologic cause of why they're out of whack. And a lot of guys, that's going to be poor nutrition, sleep apnea, smoking, other factors that could probably go into it. Testosterone alone, injectable especially, can cause elevated hematocrit. We see it. I generally don't see it go. I'd say the highest was probably where I was at. I was 57, 58% hematocrit doing injections, and I stayed around 52% on cream. When I get concerned, it's not because of the testosterone per se, but if I see a guy's hemoglobin at 20 or 21 and their hematocrit at 60 or above, I'm like, you need to figure out what's going on with your health. Like, you need to look into some things. And usually you tease it out and they do snore. They've never had a sleep study. I'm like, you got to get it. And a lot of them won't. They're like, no, I'll do it. And they never do. Sleep apnea is a huge issue. But again, a lot of this from being overweight. A lot of people they're not willing to admit that they're at an unhealthy body fat. And I'm not saying that's this guy's problem at all, or everybody with elevated hematocrit. I'm just saying, though, a lot of people, though, don't realize with sleep apnea that a lot of it is from body weight, neck size, things like that. Even muscular. It's not just fat. It's just size in general. Like, I've had to come to grips with the fact that I feel healthier and move better and sleep better at 180 pounds instead of 220 and 18% body fat, pretending like I'm big, when now I'm 180, 175 at probably 10%, but I feel better, and I have to get over this desire to just be this mass monster, because I'm never meant to be that way. And the guys who push the drugs to get that way, or if they're just naturally those bigger guys, they need to look out for sleep apnea, because it just can happen. And a lot of it's not central. A lot of it's with the obstructive, with the tongue. They can fix that lickety split with a customized mouth guard that keeps the tongue. And then you don't have to worry about the CPAP and all the crap that comes with that. So, but as far as, the alarming hematocrits, no, first of all, 54, I don't even blink twice at that on somebody on TRT at all. Again, the top of the normal range used to go up to 55% was normal. when I got into practice, when I left residency, and then it changed a few years later. So it's like people are just becoming chronically anemic. So that's the new normal, right?
Yeah.
So that's the other thing I want to tell people is statistics can't give you a prescription. Like you can't get an ought from an is. I cannot look at a statistical norm and say, well, I ought to be inside that. Why? How do you know that? That's just a description. What if everybody in that distribution, they're all diseased, right? Like we don't know. And whoever gets to define health, a healthy person in these samples, that's subjective. So you got to take a lot of that stuff with a grain of salt. That being said, if these parameters are very much out of whack, sometimes go look for a root cause. If you can't find it and people feel fine otherwise, and they're okay with that, because then that's all that matters. If they want to donate, I'm like, listen, more power to you. If you want to go do that on your own, I'm not writing a prescription for it because I don't have any evidence that it's necessary or good for you. If it makes them feel better from an anxiety standpoint, because the anxiety is driving them crazy, that's going to affect their health negatively, then go do it. I get it. I just don't want to be part of that because, again, I can't prescribe something that can be harmful for an unvalidated reason, because we're not fixing anything by just drawing off blood every now and then when the blood may not be causing the issue at all.
Mm-hmm. Yeah. Dr. Grant, I'm on 200 milligrams a week SIP. My libido is still off. Any suggestions? Lower the dose, I guess?
I would start with that, but libido is not primarily hormone driven at all. Mm-hmm. I have seen so many guys who have low T in my clinic before, or health train wrecks even, and their libidos are through the roof, and vice versa. Guys who are healthy as can be, libido's never been good for them their whole life, and then everything in between. Libido, in my opinion, like I know for my own self, my wife, like, and people we talk to, like your life circumstances, your stressors, what you have on your mind, all those things are going to play way more into libido. Your relationship status, like how good is your relationship? Are there stressors with that? But just work life, kids life, being busy, things that we see in general, especially again in Western countries, people are blowing and going all the time, and we do not put the effort into our general health like we should. We do not get relaxation when we should. We don't get out in the sun like we should. A lot of people just not ticking the right boxes. Food choices, I think, affect it as well. So there's a litany of things and variables. And I think when people try to hone in on just, no, it's got to be the testosterone. That's the one thing I need to tweak to get it up. It may be. You got to try it. The problem is you get transient effects with libido when you change your dose. A lot of guys will do that. They'll chase that dragon forever. Oh, when I ramped my dose, my libido got better for 2 weeks and then it went back. Yeah, I know. It's transient. You can't keep it like that. It's just because you perturbed the body and you pushed it out of homeostasis, and for some reason that drove libido up. I don't know why. But we see that all the time. It doesn't last. So to get a lasting libido, the other thing is expectations. Are you expecting to have, what's your expectations for your libido to be? Every day? You want it all the time? You want it every day? I mean, that's not natural per se. A lot of us, as we age and life does get busier, people just don't think about sex as much. And a lot of times that gets better after retirement when people, again, have more free time. Like when we go on vacation, sex drive is better because we're relaxed, we're enjoying, we turned off a lot of the switches that are keeping us distracted. So you have to think about all that too, is where should your libido be based on the life circumstances you have at the time. And I think people have got to start being more self-reflective about that for sure. I'm not knocking that the hormones might affect it, because I have seen where libidos were great and then you add in a hormone and all of a sudden libido seems to tank. Again, is that proof of causation? No, because other things could have been going on at that same time. But it's worth exploring. It's worth going, well, let's see if we can tweak your protocol a little bit. My libido did improve when I switched from injections to cream, but guess what? I changed other variables in my life at the same time. And I'm not like a walking horn dog. I mean, it's just, I was more receptive when the time came. Just because I felt better. I just felt more mentally clear with cream than injections. I didn't have the brain fog. So that made me more receptive from a libido standpoint, but it's not like I'm walking around like a teenager. You know what I mean? Like because that should change as we get older, when we understand the meaning of sex and the meaning of relationships. I think that libido should probably change over time too, but that's a different topic.
Great advice, Jordan. Great advice. All right, let's continue into this chat box. I'm on Testo Gel for the last 3 years, 4 pumps daily. What would be a good equivalent dose if I move to cypionate via sub-Q?
No, you can't equate, you can't convert gel doses or cream doses to injections. You just got to start somewhere. So there's no way to do it. Gel's pretty much crap for most people. Every now and then you find somebody, but 4 pumps a day, I rarely see people get over like 500 total T on even 4 pumps of gel a day. It's just crap. So you can get a level of 500 with 100 milligrams a week of testosterone easily for most people. So it'll probably put them higher than that. So you're looking at a pretty low equivalent injection dose to compare to 4 pumps a day of gel. But if you switch, you just pick a reasonable starting dose. It's going to depend on your provider. Some start, I think, too low. I'm a little generous probably with my starting doses. I generally start people around 80 milligrams twice a week. I think that's a good happy medium starting point, and we just work from there. So for some it's too high. For most, it's actually not. And sub-Q, that's on you. If you're starting injections the first time, I would not start sub-Q. I would start with IM, is how it's meant to be given. I've yet to see people feel better with sub-Q when they move from IM to sub-Q in general. Every now and then there's a one-off, but in general, people, for equivalent levels, people seem to feel worse with the sub-Q administration. And also, if you're going to do sub-Q, I would recommend getting a very thin oil like MCT oil to do it, not doing the commercial cottonseed or sesame oil. Yeah.
Mm-hmm. Steve writes, I'm a huge fan of the channel and Dr. Grant. Thanks for all the awesome info. I've been sifting through Traverse trial data, with the trial being 1.62% gel and mean ranges of 350 to 450 achieved. It doesn't seem compelling to me. What am I missing?
No, I agree. It's not. I mean, they're not looking at the levels that we see in practice. So I think it's great because of the conclusions they kind of drew, but they're not as powerful as they want them to be. That being said, I can tell you from practice, my own, with thousands of guys and other practitioners who treat many more than I do, who are okay with higher than normal, quote unquote, levels. You don't see an increased incidence of MIs or strokes or any. You just don't. You're just not seeing it. My patients aren't dropping like flies. They aren't having DVTs. And my guys we're not donating. We're not on aromatase inhibitors, all this stuff. But I agree about the Traverse trial. Again, you got to take these trials with a grain of salt and go look and see how they're done, because a lot of times they're just really garbage. And so you have to look at the details. That's why I was talking about the Sloop peptide earlier, and go look at the actual study, and don't just read what they say. Go look at the graphs. Go look at the scatter plots. Go look at all those things and go, it's all over the map here. Anybody can draw a best fit line or curve through some scatters, but that doesn't mean anything from an individual standpoint. Most research is crap. I'm just going to go in. It just is. The best you can do with these kind of correlative statistical studies is try and falsify something. But even to falsify it, you got to be comparing apples to apples. Like if we really wanted to do it in our realm, we'd have to look at people with our protocols being done over time with huge groups and higher numbers, and then it's not going to be done. They're not going to run those kind of trials in the normal medical world because they already think we're crazy. Yeah. So is what it is.
All right. Recently, I heard Dave Lee talk about 3 times a week dosing as optimal for TRT. Do you think 3 times a week can have positive effects on hematocrit as well as all things TRT?
Good question. Yeah, I haven't seen a huge difference. I've seen guys who even go down to daily thinking it's going to improve their hematocrit, and a lot of times they actually just goes higher. So it's individual though, again, and we don't know what's driving that hematocrit. If it's solely TRT, if there's something, other variables in people's lives they're not changing or not cognizant of. I haven't seen a huge difference between twice a week and 3 times a week injections in general. And you'll see that in our group a lot. A lot of guys will say, yeah, I went from twice a week to 3 times and I felt no difference, so I just stuck with twice a week. It's all individual though. There are guys who swear by the more frequent, and Dave talked about, optimal being daily if you can do it. And I'm like, I mean, theoretically, I think that's probably true. Although I have guys that have done daily and feel no different than twice a week. And they're like, why would I do daily if I felt the same? So it's down to the individual. I don't think we can generalize it and universalize it to this is the only way to do it. It's going to be the same thing. And I don't think you don't need to chase the hematocrit. That's what people are missing. Same thing with estradiol. They're like, okay, I get it, but what do I need to do about my estradiol? And I'm like, well, then you don't get it if you're still trying to ask about it. And so this idea of managing the hematocrit with your frequency of injections, you're missing the forest for the trees. You need to base your frequency of injections on how you feel. Because if you go and feel worse on 3 times a week, and it might move the hematocrit at one point, well, you didn't just do yourself any favors, right? Like, because you're chasing the wrong metric there, because there's no evidence that that metric in and of itself is bad. And that's what people have to get out of their mindset, that these red numbers on a lab are bad. Those normal ranges weren't made for people taking the substance. If you got normals with all men taking testosterone, then the normal range for hematocrit would be different. And that's okay. That's just because it's a different patient population. It's the same thing with carnivore dieters. And I'm a huge fan of carnivore for the right people, and even for myself at certain times. The lab ranges for cholesterol and all these things weren't developed with people on carnivore diets. So you can't compare the two, and you can't say, well, these people over here in the normal that we consider, that's the right range to be in, and therefore all you people on carnivore are wrong and you're going to die. No, you can't make that claim at all. In fact, that's not what you're seeing happen. The lab ranges are just the lab ranges, and they change with external inputs. That doesn't make them bad or good. People got to stop moralizing the labs, in my opinion. Yeah.
Dr. Grant, you mentioned you have some experience with anabolics. How would an average person go about trying anabolics for performance reasons? Mostly, how do I trust the source of the actual compound? Let's just add a little disclaimer that we don't promote nor condone the usage of anabolics here.
Yeah, I can't answer as a medical doctor. Obviously, I can't tell you how to source anabolics. But in the past, yes, I have played with a lot of things, and you don't know what you're getting is real. You really take it on faith. And you hopefully use somebody's source that you know that they use something real, but even they don't know. They just got results. They don't know that what they were taking was what they thought they were taking. I think, again, this is why I'm more on the conservative end of things. And one of the least faked things would be testosterone. And if guys have never tried bumping the testosterone for a long time, low and slow, that's how you get the gains. Muscle. These guys thinking I'm going to do a 10-week cycle and I'm going to blow up with muscle. No, you're not. It's not muscle. There's a reason people shrivel back down. Even professional bodybuilders, look how much weight they lose when they get off gear. It wasn't real muscle. It's not. It's water. It's inflammation. It's all these other things going on. It's not literal tissue. If it was literal tissue, you would not lose that much that quickly. And it's the same thing when you stop a little short cycle. Whereas somebody takes 300 milligrams a week of testosterone with 0 negatives and works their butt off and eats right for 2-3 years and might slowly bump that dose up, you're going to be ahead of the game on the actual muscle tissue side of things, in my opinion. I mean, I did crazy, stupid stuff in college, and I never looked that, I blew up with water, but I did like 1,250 milligrams a week of testosterone it's stupid. Whereas years ago, not that long ago, I did 200 a week of testosterone, 200 a week of Masteron for like a year. That's like nothing. It's not even a starter cycle for most people. I looked better than I ever had at that point. Now I'm leaner now than I ever have been. I think I look better now than I did then. And all I'm on is my testosterone cream. But it just time and effort, you can't replace that. So that's just what I would say. But as far as trusting sources, shoot, I've been out of that world for so long now. Like even when I was in it, I didn't know who to trust. Unless you have access to it directly. It was a lot easier pre-2001, back in the day, back in the good old days when before 9/11 and all the crackdown on the borders and everything. I mean, there was a lot of cool stuff at that time, but I think those days are gone.
How much is a reasonable amount of testosterone to take a week for a beginner? I guess as TRT?
Oh, it's TRT? Yeah. It just depends. Like I said, I start people, my general starting point is really around 80 milligrams twice a week for test sip. If I start them on cream, I start everybody at 2 clicks a day in the morning only, just to assess how their body absorbs the cream after 3 or 4 weeks. I want to make sure they absorb it, see where those 2 clicks put them as an individual. After that, it's off to the races with them trying, where they want to be, if they want to do twice a day or not. If their levels are at 2,500 on 2 clicks, I might be like, hey, try 1 click now. Oh, hey, let's reduce the concentration. Or if their levels are 600 on 2 clicks, we might be like, cream may not be for you. I mean, we'll still try it, but there's a happy medium of absorption but it gets cost prohibitive if you're one of those poor absorbers. But yeah, it's going to totally depend on your provider. I know providers that start people on the low end. I think 100 milligrams a week total is probably as low as one should be started. And even then, that's pretty darn low for most people. If you start them with frequent injections, it probably will be okay. Like if you did a daily or every other day, but most beginners aren't going to do that. I just feel like a starting point of 140 to 160, 140 to, somewhere in there, total weekly is a good starting point. And then, but it's always about the individual and how they respond to it, and then adjusting based on how they feel.
Yeah, for cream, it also depends the base in which the testosterone is compounded.
Yep.
I already shared it in another video, but I've used for 6 years, I guess, 2 times 3 clicks a day, 20% in a liposomal base, just to get levels of 1200 nanograms per deciliter total testosterone. Then last year I switched to HRT base, and for this to reach the same levels, I can get away with 2 times 2 clicks a day.
Yep,
so
exactly.
Less cream. It's cheaper for me.
Exactly. That's
still the same.
Exactly. And that's I want to help people with the cost part of it too. So I'm always like, I start everybody with a Trevis base because that's easy to get here. I think it's a little edge above HRT as far as but they're very similar. And I had good results. I started with HRT base. I like a Trevis as far as the consistency of it, the way it dries, a little better, but otherwise it's pretty equivalent as far as absorption and levels. The liposomal, I have not seen. I feel, and I can't remember, I have talked to my wife about it, liposomal tends to be better for females to the vaginal mucosa. I think it's specifically best for that area. And when guys try to use it on scrotal or even regular skin, it's just not going to absorb the same way. I have to confirm that, but I think that's the deal with liposomal.
Yeah, well, I get the same absorption from 4 clicks total instead of 6 clicks on the liposomal base. So.
Nice. Yeah.
All right. We're almost there. How do you handle younger guys, 18 to 30, with low T symptoms? Do you try to jumpstart with HCG, etc., or straight to TRT? What about when they're concerned about future fertility?
Yeah, good question. Now, HCG is not a jump start because it shuts down their natural production just like testosterone. So there's no point in doing that. I don't like the whole put you on Nolvadex or Clomid for a trial period. I mean, if they've been on anabolics, it might be reasonable if they want to do that. If they hadn't done a PCT, I don't think PCTs are even necessary, but it's a mental game with people. So I have done that with a couple guys in the past. I had like a 17-year-old come to see me when we were a urologist. His testosterone was like 20. So you already know, and he'd been taking SARMs. And he didn't want to start TRT. So I'm like, okay, let's try 2 months of tamoxifen, try to just see if it ramps things up. And then you got to come off of it to see if it remains. And it did. He may have rebounded anyway without that, though. That's the thing. But they were freaking out at the time. So it's sort of a mental insurance thing to do the PCT. I like tamoxifen over Clomid just because it's better tolerated from a side effect standpoint. But we just have a conversation. If it's an 18-year-old, 20-year-old, it depends on their maturity level, depends on their lifestyle. A lot of these guys are actually very mature for their age. They've already been through the rabbit trail of testing, and then they end up coming to me at the end. You're not going to find just, for somebody like me who's a cash pay clinic, most 18, 19-year-olds aren't going to want to come pay that anyway. So if they're coming to me, they probably have already been put through the ringer with traditional doctors and testing and been tried on things already that didn't work. And I've had that from a lot of guys who, to maintain fertility, were put on freaking letrozole, crashed their estradiol. They feel like crap. They can't get an erection. And their testosterone is now 700. Who gives a crap? They feel terrible. So what we do is we talk about testosterone. We talk about the fertility potential risk. It's not a given. Again, we're back to expectation setting and informed consent. And once we go through all that, we just have a discussion about what they want to do. And if they do want to pursue TRT, I think a trial of TRT is fine. I like cream better for that purpose because it's in your system quick. It's also out quick. So if they end up not getting any benefit after 2 or 3 months, it's out. They're not going to be any long-term probably harm, and probably not from injections either for that matter. But we talk about fertility for those guys that are that young and they don't have kids and they want to have kids. We do an upfront semen analysis because I want to know what their starting baseline is. Because what if they're starting with a 0 sperm count? Well, if they don't know that, and then they get a test 6 months down the road on TRT, and then they're 0, what do? They blame the TRT when it may not have been the TRT. A lot of guys these days have very low sperm counts just at baseline. So I have them check a semen analysis up front. I tell them to freeze the sperm just as an insurance policy, unless they know for a fact they would never do in vitro. But most guys at 18 don't know that. And so I say freeze the sperm. That way you've just got it on hand in case. And then we monitor down the road. And if they want to go on HCG alongside the TRT, we still space that out. I don't do it up front because I don't want two variables at once. I don't know that HCG the whole time is necessary versus pulsing it in when needed with FSH if their sperm counts go to 0. There's no good way to know that. I know Dave Lee's talked about that too. Again, I go to the patient comfort level is what matters for me. If they feel better mentally going, no, I just want to take it every day or every whatever, I want to take it alongside my TRT, that's fine. We still got to monitor semen analyses either way, you know? And if that starts tanking, then we talk about adding in follicle stimulating hormone. And for now, that's available. There's a compounding pharmacy making it that's affordable. If that goes away, I don't know what we're going to do. I'll probably be advising them to seek out HMG from India, to be honest with you, because that's still better than coming off and getting on a aromatase inhibitor or Clomid or any of that because you just feel like dog crap. Yeah. But
all right. Any idea how to fix the heart palpitation from TRT, regardless of how low the dose is? Possibly an electrolyte imbalance? ?
Yeah, that's the thing is look at other variables for sure. Electrolytes are huge. I've finally had to start adding electrolytes. Like I just add Himalayan sea salt to my water when I drink it because I think most of our water, doesn't have any of that in it. It's not like we're all drinking natural spring water with minerals in it. So I do think adding that back is important. Look at your stress levels. Look at your mode of administration. I have seen a lot of guys who take injections and they switch to cream and they don't have the issues anymore. Not all of them, but I do think there's something with injecting the oils, preservatives, the body may not like, not everybody's body may like that. Same thing with acne, tons of acne due to injecting oils and they get on cream and their skin clears up within 2 months. So always look at those other variables and can't always blame it on the testosterone level per se. Every now and then I have seen guys where it seems like no matter what they do, their body doesn't like testosterone. And I don't have a good answer for that. I'll be honest with you. It's so rare. So when that does come up, it's very frustrating because I don't have enough numbers to even draw any kind of correlations or patterns from it because it's so infrequent. But I have seen it a couple of times where some guys are like, but then sometimes they'll come back a couple of years later, they want to try again and they're fine. So it makes you wonder, what are there other stressors or things going on in their life at the time that they just didn't even know about? And that's a lot of us. We don't even know the things that are affecting us all the time, day in and day out, bringing up elevated heart rate, panic attacks. Like I've had it. I had it last year in February, March. I literally went into AFib. I was so stressed out and was constantly worrying about things. And I don't even know what it was at the time now that all of a sudden I feel my heart racing and I check it and I'm like, I had my wife come over there and she's like, yeah, I'm pretty sure you're an AFib. And I had to really calm myself down and it went away by the next, and that never came back. But again, my point is stress and anxieties and things like that can also play into it, but it may be the hormones. So check the dose for sure. Check the mode of administration. If you're on injections and you've never tried a topical cream, I think it's worth trying just so you can at least compare.
All right, last question. What do I do if my doctor tells me I need to donate blood, but I feel completely fine for over 4 years? Hemoglobin was at 18.7, hematocrit was 57.
I mean, that's going to be up to you and how comfortable you are standing up to your provider. I wouldn't want to joust with a provider. A lot of these people are very passionate about where their stances are, even though they have no clue about this topic. That's just how they roll. That's common in medicine. It's common in life. People are dogmatic about things they've never actually studied. Yeah. And so if they're cool with you doing that, if they just sort of flippantly, recommend it, but then you're like, no, I'm good. I feel fine. I don't think there's any issues. And they're like, okay, well, that may be fine. If they're like, no, you have to do this to the point where they're changing your dosing and withholding it, find another doctor. Like there's no reason for that. 4 years, hematocrit 18s, upper 50s. That's very common with guys on TRT. And, I was that guy. I had a hemoglobin in the 18s and a hematocrit 57, 58. I felt fine. And I didn't have any strokes or blood clots or anything like that. So all these people making claims about being causative, you're not seeing that in reality. You can theoretically think about that stuff all you want and say, well, this could mechanism. It's like, no, it doesn't matter. I can come up with any explanation for it, but it doesn't matter if it's not true. So, but back to your question with the doctors, yeah, that's going to come down to the personality of the doctor and how comfortable you are. I mean, some people want to literally joust with their doctors and be like, "Oh, you claim that? Well, give me backup for it. Show me studies." And they're not going to do that. Those doctors are not going to go look up studies. Most of them. Now, some might, if they're open-minded, they might go, "Oh, that's a good point. I don't actually know that. Let me go look into it a little bit." Most won't do that. And even if they do go look into it, they won't know how to look into it. They'll just go find some abstracts and read them out and some correlative studies and just call it as fact. So you got to find the right provider if you really want it. That's going to look deeper in these things in an open-minded way and kind of sometimes meet you in the middle on these things, because it really is about that in the end. But they have their boundaries too, and that's fine. If they're set on their boundaries, it's not right for us to try to push them over those boundaries. If they're not comfortable, just like guys do with me, if they're like, "No, you need to prescribe an aromatase inhibitor," I'm like, "You need to find another doctor, because that's my boundary. I am not going to do it." So either you live without it, or you do it on your own, or you go find somebody, and that's okay. Like, we don't all have to agree, and I don't want people paying me who don't agree with my philosophy on things, right? Like that's the beauty of the market and choices, is that there's so many different ways. So yeah, find somebody if you can who's like-minded. But if you can find somebody who's just cool and they're just throwing that out there as a recommendation, but they're not being like stickler about it, that's probably fine too.
Exactly.
Yeah.
All right, Jordan. That's the end of the questions. It was really enlightening again. So thank you so much for your time.
Absolutely.
To wrap things up, how can people reach you if they want to?
Yeah, so our website is granthormone.com, but anybody can email me directly. I mean, even if I'll tell them up front if we're not, accepting a patient from certain state, or some guys do want like good advice on other providers where they can find. I'm like, I don't really know a lot of that. I'm happy to answer them, but a lot of times I don't have the answer for them. But just they can email me directly at jrgrant1@granthormone.com. And I'm happy to help where I can, because I do want people to find good providers where, if I know of some in other states, if they need them, it's just slim pickings out there. It really is. Unless they want to do, there are a few like Gill's Clinic that service, the states and everything like that. Not everybody some people want to try to find somebody they can go to in their state. And that's where it gets tricky, honestly. But I think it's getting better. So we'll see. But anyway, yeah, reach out to me that way. And thanks for having me on. It was fun.
Yeah, thank you so much, man. And for everyone viewing still, join our TRT and hormone optimization Facebook group, because the other group with 17,000 members was deleted by Facebook for no reason whatsoever. Right. So we started again. We're now at 1,800 members. But join us there, because you can ask all your questions there for free. Jordan is very active in that group as well, so you can tag him there along as well. So absolutely. Thank you for watching. Thank you, Jordan, for spreading your knowledge, and talk to you next time.
See you guys. Thank you.
Okay, bye-bye.